Well, good afternoon, everybody, for SADS Live 150. Great to get to be with you once again on this beautiful Friday the 13th. Ooh. Well, I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic, and our complementary Winland Smith Rice Sudden Death Genomics Laboratory. I've had the privilege of serving as president of the board of the SADS Foundation for many years now, and have been delighted to partner with our CEO, Alice Laura, who created and conceived of this idea of SADS Live, which we launched in early 2020. And so we're now at episode 150. My boss, Alice Laura, gives you greetings. Our staff, Aaron, who does all the magic behind the scenes, thanks you for joining us. We can't wait to see what questions you brought for this Friday of September. As you know, we used to do every single Friday during the first 2+ years of the COVID-19 pandemic. We switched to twice a month, and it's amazing how what used to fit into every Friday, now twice a month, it gets harder and harder to make it fit. But I love it, and I love being with you, and I'm here on vacation, our last vacation week at our place in Wisconsin, my wife's parents' lake place. And so if the color and the lighting isn't as good, sorry, I moved to 3 different rooms, and but here we are. Announcements. SADS International Meeting is coming in early November. I don't know if you have it on your calendar, but you should. It's in Chicago. We'll post it for you as the reminder. It's going to be great. I love the time with the teenagers, no parents allowed. I love the fireside chat with the families to just take all of your questions as best I can, and like we do here on SADS Live. Let's get started. And as you know, there's no prep. So I do my best to glance over the side, see your question, keep it pithy, and then try to respond. So first one, so I take them in order, and let's go. And we have Jen from Instagram, and we have all the social media platforms. So whether you've joined us from Instagram or whatever venue, great to have you. If you're a long QT family, we love our long QT families, CPVT, Brugada, ARVC, ACM. I hope you feel that this is your home for information, for resource, for comfort, for hope, and to have your questions answered. Some of you are my patients personally, and for those who I get to be counted as your personal genetic heart disease specialist, long QT specialist, CPVT, I love taking care of you and your family. For those where I haven't had the privilege to care for you, I love taking your questions and trying to give you as much information as we can. So here we go. Jen, you get number 1. Your daughter is 10 years old with LQT2 and seems to be doing great on Nadolol. That's awesome. What types of symptoms would prompt me to consider mexiletine? Oh, great question. So mexiletine has an incredible story. It is what's called a late sodium current blocker. Some of us view it as sort of the oral version of lidocaine, which is an IV medicine. And Peter Schwartz and his team in Italy were the very first, some 28 years ago, to reveal what we then called genotype-specific therapy with the use of mexiletine in type 3 long QT syndrome, LQT3. The LQT3 gene, SCN5A, was just discovered and published in the journal Cell the year before, 1995. And within a year, Peter Schwartz had the idea of sodium channel problem due to accentuated late sodium current. What if we use mexiletine? And not surprisingly, it worked. And so for years, decades now, we've been using mexiletine almost exclusively for LQT3. About a decade ago, my team published, along with Peter Schwartz, our early experience with using it in LQT2. And we saw in some patients incredible shortening of the QT interval. Fast forward to 2024, major paper just came out from our groups in the journal Circulation of our extensive clinical experience and bench to bedside experience, including the bedside of LQT2 rabbits, showing why mixilotine works. So LQT2 patients, as it turns out, their disease mutation in the LQT2 gene causes loss of IKR current, that's LQT2, but then secondarily, that loss of IKR causes the normal intact sodium channel to acquire late sodium current properties as if it had its own LQT3 mutation. So many LQT2 patients, when their QTC is above 500, they in reality are LQT2 plus acquired LQT3, if you will. Now, this is all new, so that in fact, most of your specialists who care for you may not even know this yet or have incorporated this understanding, but you're ready for it. So when do I use mixilotine in LQT2? I use it for many of my LQT2 patients if their QTC is above 500. I use it for my LQT2 patients if on beta blocker and below 500, they had a breakthrough event that we weren't anticipating. I use it for my LQT2 patients who've had appropriate ICD shocks. If a decision was made to add an ICD and we want to see if we can shorten their QT interval. Now, this has not been codified in guidelines yet, so this is how expert centers like ours at Mayo Clinic, like Peter Schwartz's in Italy, how we are starting to use mixilotine in patients with LQT2. I hope that helps, Jen, and I can't wait to meet you at our conference on November 8th and 9th, which is the next reminder here, SADS International in Chicago. Lucy gets our second question. With somebody who is usually in borderline Brugada ECG over several months and has experienced 3 episodes of cardiac syncope with seizure, what value does a Brugada-specific EP study with a procainamide challenge have? Genetic test negative except for RYR2. Interesting question. It was a little confusing, and only not that you've made me confused, but that RYR2 is never a gene that we think about in the context of a Brugada diagnosis. So I'd have to understand what was found in the RYR2 encoded ryanodine receptor, which as our CPVT families would be raising their hands and say, that's my gene, because that's the most common genetic cause for CPVT, and mutations in RYR2 account for about 2/3 of all CPVT families. Now, Brugada, the question, I love it because it's a diagnostic challenge. So if I have a patient whose Brugada ECG pattern is quote unquote borderline, meaning they're not showing the so-called diagnostic type 1 Brugada pattern, but as the physician, my patient has fainted and has fainted in ways that I have not liked, I've concluded that it's cardiac syncope, meaning the heart's to blame for the faint, either because of a rapid arrhythmia from the Brugada or from whatever heart disease we're invoking, making the heart go into a dangerously fast rhythm that forces the patient to instantaneously collapse, otherwise known as fainting. And so if I am going to call my patient symptomatic Brugada, then I don't need further diagnostic testing to know that I now need to treat their symptomatic Brugada beyond just Brugada preventative measures, drugs to avoid, brugadadrugs.org, and so forth. Those treatments may be for cardiac syncope, the medication quinidine, used often with my friends and colleagues in Israel, or going directly to an implantable defibrillator. So when I hear somebody say they're having cardiac syncope, I have to figure out for myself, do I really believe that those symptoms, that faint, is coming from the heart? And if so, I may or may not need further diagnostic evaluation before I increase their treatment program. Best wishes with that, Lucy, and great questions, 2 in a row, which is off to a great start. School materials from SADS, check it out. Back to school, yeah. I can't believe looking out at our lake, there's no boats out on the water. Everybody's back to school. Couldn't even get our boat filled at the gas station. They were heading out for camp, so I had to do an emergency fill up. Anyway, more than you wanted to know. But the SADS Foundation website, www.sads.org, has incredible resources, all complete back to school packages, so that you should not have to be taking your SADS diagnosed child, whether it's old diagnosis or a brand new one this summer, with any fret, fear, or worry. Remember, do not fear. And Carrie's question, number 3, comes to us. And can you have ARVC along with CPVT, or is this a similar presenting condition? Oh, question of the day. I love this question, Carrie. So all of our ARVC families, we know that the genetically found forms of ARVC are due to mutations in genes that build so-called desmosomal proteins. And really exciting, a week from now, we will be in day 2 of an international ARVC summit, collecting about 70 thought leaders throughout the world for a ARVC symposium in Zurich, Switzerland. So we'll be flying over there on Wednesday. It's half day Thursday, all day Friday, half day Saturday. And it's the meeting of the minds to advance in our knowledge globally about ARVC, to put together some new guidelines and recommendations, not guidelines officially, but recommendations from the ARVC thought leaders. So we'll bring back a report of some of the highlights from that ARVC International Symposium. It's next week. Those ARVC families can be thinking about us, that we would be working hard, which we will. Your question, though, I love it, because the ARVC, the disease of the desmosome, we now know that it can sometimes show itself in what we've called a pre-cardiomyopathic electrical expression of the disease. Let me unpack that. What I mean is, before the ARVC patient's echo, or the better imaging modality, MRI, has turned negative, has turned abnormal, showing the ARVC muscular disease of the left ventricle or the right ventricle or both ventricles, while the heart is still structurally perfect, at least by eye and by echo and by MRI, there can be electrical irritability such that the person during exercise can have an exercise-triggered arrhythmia. And we published, our group and our group from our colleagues down in Sydney, Australia, showed that stress test can look similar to CPVT. And it turns out that it's not all that similar, but it's similar only in the sense that there's irritable ventricular ectopy, extra heartbeats from the ventricle that start coming out during exercise. And so often we'll see exercise triggered ectopy, heart looks normal, so then we think CPVT, we ordered the genetic test, and instead of seeing a CPVT mutation in the RYR2 gene, we see the mutation in one of the classic ARVC genes like PKP2. And our PKP2 ARVC families will say, hey, that's mine, that's mine. And I'd be curious to see if any of our ARVC families had their PKP2 discovered from an abnormal stress test before or while their imaging tests, echo or MRI, were still normal. Maybe we can get any ARVC families to respond and say, yep, that was me. But that's the explanation. Julie's question. Hi, Julie. I don't have my hat. I should have brought it with me. But Julie, great to see you joining us today. Does sleep apnea pose a risk for long QT syndrome? Answer is maybe a little. Now, sleep apnea should be addressed on its own purpose, for its own merit. Whether sleep apnea makes an LQT2 person's LQT2 twitchier, that answer is a little bit. So yes, get sleep apnea addressed, but don't be fearful that it's going to make a person's long QT, explode in a dangerous rhythm just because you're going to snore tonight. That risk increase is not that big. Statistically, it's there, it's measurable. So get the sleep apnea treated, but don't be afraid of your long QT. Kiara, if I said that right, love that spelling of that name, beautiful name. How can I maximize the longevity of my leads and minimize any damage breaking and things like that? Any exercise or movement to consider doing? I've heard about don't do too much push-ups. Oh, good question. Honestly, my view is you should do any and every activity you love. I don't tell my patients with defibrillators to refrain from push-ups. It is known that repetitive over exercise, especially if the defibrillator is below the collarbone, that repetitive motion of the upper extremities could pose irritability to the leads, potentially increase the wear and tear on them. That's sometimes why we start thinking about different ICD configurations based upon what is it that you do, you love to do, and maximize it. So for example, a golfer who loves golf, I might not put that defibrillator right there where there's going to be that repetitive motion constantly. A basketball player, I may not put the defibrillator right there where there's going to be all of this, volleyball and so forth. But if you aren't doing organized competitive sports and just doing life, be active, exercise, stay fit, and I wouldn't be thinking of things to necessarily avoid. Now, if you're doing high volume repetition of the upper extremity, maybe, and that's where your device is, the classic ICD under the collarbone, then maybe trim back on that repetitive motion, but that would be about it. Lynette's question is the next, and I'll scroll up to see it. My son has trisomy 21 and a CACNA1C gene mutation. So far, he only has EKGs and few are in the 450s. What would I recommend for him as far as monitoring or a Holter monitoring stress test? He also suffers from hypoglycemia and on occasion with tachycardia, heart rate at 190. So really good question, Lynette, and thank you for sharing that. So for some of those who wouldn't know, trisomy 21 is also known as Down syndrome. I've had the blessed privilege over my careers to take care of many Down syndrome patients. In my life as a Taekwondo instructor, one of my all-time favorites is Chip, who I taught his way to black belt. And so her son with trisomy 21 or Down syndrome, I'd have to understand about that extra mutation to know what importance am I going to add to that CACNA1C mutation. True, irrefutable disease mutations in it that can cause the calcium channel to have increased calcium channel activity can give one of the forms of long QT syndrome, and we have called that LQT8. And then if that mutation, and there's a smaller number of them that have a very specific multi-system syndrome, not just the heart, and if they have all of those features of Timothy syndrome, we call that mutation, say G406R, for example, a Timothy syndrome causative mutation. So there's pure isolated long QT syndrome, LQT8, and then there's this multi-system syndrome of Timothy syndrome. And then there's noise, meaning the mutation is graded as reported out. It might be called pathogenic, but it's not. false positive, it might be stuck as a VUS, variant of uncertain significance. And when I see somebody with that a reported calcium channel mutation, and yet their QTC is only in the 450s, I start to get suspicious because, for example, the Timothy syndrome mutation in the calcium channel basically never has normal QT intervals. And the degree of QT prolongation is also never subtle. It's usually wow. And so I would want to get myself convinced as to whether we're dealing in the case of your son as a child with trisomy 21 and a calcium channel disease mutation, or whether we're dealing with trisomy 21 and a variant of uncertain significance that may not, in fact, be that relevant in your son's health journey. So I would need some detective work. And so whoever is working with your family, that's the kind of detective work they would be doing. When I'm monitoring somebody, regardless, I do use the 24-hour Holter when they are age eligible. And depending on your son's fitness situation and ability to do a stress test, I do a treadmill or a bicycle stress test to look at the performance of the QT interval. Best wishes with that for Lynette's son. And Jennifer's question, identical twin daughters were diagnosed with long QT syndrome at Cincinnati Children's. I have great friends there. Their genetic test didn't show the genetic cause. What would be the next step? We have 4 other kids. They're also very active high school volleyball players. I love the question. That's part of the purpose of our program at Mayo Clinic, is to discover the undiscovered. So there's not much left undiscovered in long QT syndrome. We now probably have explained about 80 to 90% of all long QT syndrome. So if a person really has long QT syndrome, no doubt about the clinical diagnosis, the genetic test spell checker should come back positive at least 80% of the time. It's pushing it closer to 90%. We recently have found that some of those who test negative, that is the 10 to 20% who really have long QT syndrome but have a negative genetic test, some of them are turning out to be LQT1, but in regions of the LQT1 gene, say for example KCNQ1, that's not explored by the commercial test yet, meaning the deep intronic spaces that aren't vetted or covered or surveyed or sequenced or analyzed by the contemporary genetic commercial test. And where we're suspicious of that is, let's say you looked like LQT1. Your T waves looked like LQT1. Your T waves and QT reacted like LQT1 on the stress test. And yet the commercial test was LQT1 negative. In those individuals, we bring their sample into our research lab and sequence their entire KCNQ1 gene, searching for deep intronic mutations. If that's not the case, and we have identical twins who show the QT prolongation, and mom and dad do not, and siblings do not, and the way you say do not is we need to know their ECGs. Is mom, dad, and siblings 1, 2, 3, and 4, do they all have normal ECGs? If so, then there are programs like ours that have offered research-based genomic sequencing, where we would take the samples of the 2 twins, the identical twins, and mom and dad, and sequence their entire genetic code. And when the ECGs of mom and dad are negative, we would be looking potentially for something that arose new in the identical twins in the early hours after their conception, and search for a de novo variant. So families who are gene test negative but have a definite QT diagnosis or CPVT diagnosis, that's what the research laboratories are for, that have set themselves up in the discovery mode to try to find the next new long QT. The next new long QT, they're getting fewer to find, harder to find, as we have found 80 to 90% of all long QT syndrome. So although our lab has published a lot of the minor genes, we haven't had a new disease gene in several years. We're working on two of them, but those two brand new genes are probably only the cause for those two families that we're searching for. But the searches and our efforts continue. The recommendation for short and sweet, great question. Thanks, Erin. She's always trying to help me. Lucy's getting a follow-up question. Now I have to remember what the first one was. How would you determine if the patient had now I remember. True cardiac syncope versus other types without a loop or a heart monitor? Oh, great question, Lucy. So this is how I do it for the evaluation. If in hearing the story of the faint, the circumstances of the faint, I've concluded not cardiac, clearly vasovagal, sounded vasovagal, acted vasovagal, it's vasovagal, which is way more common than cardiac syncope, then I sort of ignore the spell, because all of our long QT families, CPVT, ARVC families, every one of them, Brugada, they also have the opportunity to have the normal faint. And it turns out that about 15 to 25% of the planet, or at least the United States portion of the planet, faints before their 25th birthday. So fainting is really common. And there's no reason why long QT patients, CPVT patients, Brugada patients are insulated from that frequency. In fact, I think that long QT patients might be slightly higher chances of having the normal faint as well. Great. So you really have to size up the spell. Now, if I don't like the sounds of the spell, I envisioned that the reason for the faint is that the heart went into the danger rhythm. I don't need to prove it because my mind has proven it to my satisfaction. That means I need to escalate therapy. Where I use the loop recorder, and I use it and I like it a lot, and I like it way better than the Holter if I'm suspicious, because if that faint I can't designate very well, sounds a little vasovagal but not perfect, some features of heart syncope but not enough for me to say guilty as charged, that's where I use the loop recorder, and I always use it after the first time. I don't like it when I see, and I've seen patients who've had 1 spell, 2 spells, 5 spells, and everybody's waffling on, is it the heart, is it not the heart? After the first spell that I don't feel like I can classify to my satisfaction, that's when I invoke the loop recorder. Very simple gadget, 3-year battery life, so that if they have spell number 2, we immediately can have rhythm spell correlation to know what was their rhythm when they did their spell. And if it recorded nothing, then I know it's not the heart to blame. If it recorded torsades during that spell, then we immediately put the patient into the monopoly penalty box. Do not pass go, do not collect $200, go to gel, until we treatment intensify. The number of times that we've had a close call where the loop recorder, while I was waffling, caught the next spell is incredibly rare. So I feel comfortable in deciphering the spell based upon hearing the story. Others who don't feel as comfortable with the spell will use the loop recorder after what sounded for sure like a vasovagal faint in the first place. And I'm okay with that, because I do think having that rhythm spell correlation is very helpful. So somebody else hearing your family story would have to decide how comfortable are they in concluding that it was cardiac syncope. And if so, then I don't need the loop recorder. If waffling, then I like it, and I would have done it after the very first faint? I love that follow-up question. You get the 2-for-1 special. 10 minutes on my counter. I better get going here. Lindsay's is with her 9-year-old son on Nadolol and Maxillatine and a pacemaker and ICD. He has a VUS for KCNH2. Would I consider not replacing the defibrillator once he's older if no symptoms and he's controlled on meds? Wow, that's a tough one. Again, I try not and I cannot give a specific advice without knowing all of the details, spending a lot of time reviewing the data, spending 90 minutes to 2 hours with the patient in their consult. So this isn't a SADS Live private consult, but as we always do, we take these excellent questions and get you into what I would be thinking about for that. Now, the issue of device explantation or device discontinuation is incredibly difficult. So for me, what I do when I inherit these patients who already own a defibrillator is I decide, would I have done that? If I had met you, that person now or then, based upon the profile and what I would have assessed as the risk, would I have felt that I needed to take the defibrillator out of my toolbox? And if I did, then I have to be really comfortable to say, well, I did then, but I don't need it anymore for a variety of reasons. They've outgrown it. Their risk has moved lower. We shortened their QTC dramatically on therapy with the Maxillatine or whatever. On the other hand, I have a lot of patients where I inherited not only the patient, but also their defibrillator. And I never would have put the defibrillator in the first place based upon my assessment of their risk profile. So in that setting, I don't feel an obligation to continue with somebody else's decision, well-intentioned decision, but one where I might have sized up the story differently had I had the opportunity to be that family's physician from the start. So I inherit the patients. I don't feel like I have to inherit or under obligation follow the treatment plan. But if the diagnosis is robust, the risk assessment was spot on, I agreed with the ICD, backing away and discontinuing an ICD, that takes a lot of effort together to decide, is that in the child's and the family's best interest? I scrolled past, sorry. And I'm trying to go up again, and the computer won't let me. Let's see here. Okay, here we go. Kim's, do we know any risk with using semaglutide medications with ARVC? Well, so far we don't with any of our genetic heart diseases. So the semaglutide class of medications, and I don't know its trade name, so I won't misspeak, but these are the GLP-1 agonists used for weight loss. There's two major ones, one from the company Novo Nordisk and one from the company Eli Lilly. And I don't know this one. It doesn't really matter. They're the same class. But so far, there's been no suggestion of these medications prolonging the QT interval, aggravating the Brugada pattern, agitating CPVT, or bothering ARVC with sort of an inflammatory reaction. So my view, I have not yet had any reason to counsel any of my patients to avoid those medications, and instead just saw one wonderful patient of mine, hardly recognized her, over 80 pounds lighter since I last saw her a year ago in her weight loss journey. So way to go. And if you're watching, you know who you are, and congrats. Very, very proud of you, because we need to be striving for normal weight, healthy living, and counter being overweight or being obese. That is mission critical to our longevity. I need to lose weight, about 10 pounds, weigh myself every day, making progress, surfing, and that's helping. Summer's question, And Summer's asking me that she had SCA, sudden cardiac arrest, as her only symptom from her LQT1 2 years ago. Since then, QTC has never been below 550. My EP doesn't seem concerned, but is that normal? I have an SICD and I'm on 20 of Nadolol. Really good question. The 550 number, that's impressive, especially to be that number and not have an episode. And I'm not sure of Summer's age, but to go throughout life with the first episode being sudden cardiac arrest with owning a QTC of that magnitude is a little unusual. But we see it. And so that just means sometimes our patients don't read our papers. Can you believe that? And would I be concerned? Not really, because I do know that LQT1 and presumably this patient's LQT1 cardiac arrest occurred when she had not yet been diagnosed and not yet treated, that it's very responsive to beta blocker. Would I be comfortable with 20 milligrams of Nadolol in an adult as cardiac arrest protection if they did not have an ICD and did not want an ICD and we're trying to come up with an ICD-free treatment solution? No, I wouldn't be comfortable. But we have margin because we have the SICD. So in that kind of a setting, I don't feel the necessity to push the beta blocker to the level that I would need to get it pushed to if we didn't have that backup protection in this setting. And so I won't want to then make the patient joining the ranks of our self-declared beta blocker zombies if we have ultimate protection on board. Now, there are many ways to do this in terms of using Nadolol. We also know that in LQT1 patients, like in CPVT patients, left cardiac sympathetic denervation is extremely effective in those two genetic forms of genetic heart disease. And I think this might bring me to the last one. Okay, let's see it. I got to get that rolled up, and here we go. From Rebecca, asking from the ARVC group, has there been any more research on the DSP gene and whether or not exercise has a major impact on actually developing ARVC? You have it, weren't diagnosed until you were 32. Now your 14-year-old son is DSP positive and is monitored and wants to play sports, but we are hesitant. Great question, Rebecca. I hope I can bring back an update about what does everybody else in the ARVC expert land think when we come back from Zurich, in which the meeting will be next week. A full day is a week from today. So some of this is a view. I think in mice and in humans, the evidence for disease, for the potential of disease acceleration and disease agitation and disease promotion are most compelling in PKP2 mediated ARVC, mutations in PKP2 encoded plakophilin. I think the evidence is less impressive, less robust for the other genotypes, including DSP, which builds the protein desmoplakin. So I find myself not convinced for desmoplakin. I find myself very convinced that desmoplakin happens to be one of the versions of ARVC that is unmasked and revealed, if you will, by inflammatory insults. A prior episode of myocarditis might bring it out. And then when the ARVC is discovered after, like a viral illness, for example, and we do genetic testing for that post myocarditis diagnosis of ARVC, then DSP tends to be the more common genetic cause identified rather than PKP2. So there's something about an inflammatory reaction that shows DSP or nudges DSP along its evolution into disease manifestation. I'm not convinced that exercise does that. Would I extrapolate in an adolescent who is genotype positive, uh, and encourage them for now not to do long distance endurance training sports? Yes. Would I shut that adolescent down from every sport that he or she loves just because of their positive genetic tests? Absolutely no. And I think we are not doing it in an ideal way. And again, I hope we see some guidance and some collective wisdom where we stop doing this to our ARVC family, because I've seen the dark side emerge, which is some ARVC families have gotten pretty smart, because you are very smart. And they say, oh, if we don't do the family variant test, we wouldn't know whether our child was positive or not. So we'll do the annual evaluations, and as long as the diagnosis still isn't showing itself with standard tests, we're not going to do the genetic test, because if we get the genetic result, then we're getting disqualified. And I don't think this is a healthy way of doing it, but we have almost forced our ARVC families, or some of them, to use and think through this strategy rather than informing me, letting me know which one is positive, so that we can tailor an athletic pathway together in a way that continues to let sports be part of that child's life for as long as possible. And so I have a lot of ARVC athletes, and we monitor them closely. More to come on that. That is a lot. We could take a whole hour to do sports and ARVC, and maybe we should, and bring a couple of guests on from the pro side. I can be pro. From the con side, those who would be insisting to disqualify your 14-year-old son, and unpack the arguments together. Have a little SADS live debate. That might be kind of fun. But anyway, that brings us to the top. We are done with SADS Live 150. I've loved every one of these with you. The next one is scheduled for 2 weeks from today. Unfortunately, I don't get to be with you. I am going to be, fortunately, with my wife and our third son, doing a little special outing with adult children. We don't get to do that very much, do we? To just have alone time with adult kids. I had 3 days of it these last 3 days with our son Jens, and that was amazing. So we're going to do it again for an overnighter in Door County. Never been to Door County, Wisconsin. I'll tell you what I think of it. I've heard amazing things of it. Until then, I know you're going to have a great program for SADS Live 151 in 2 weeks. I can't wait to get the feedback from it. And then I'll be back with you in October. So have a wonderful rest of September. Take care, everyone.